Hello and welcome back to the EMS Handoff Podcast. I'm David, and along with my co-host Bradley.dean, we are your source for all things EMS. And if you've been watching our feed lately, we've been a little bit behind. So Bradley, we are back to rocking and rolling with the EMS Handoff Podcast. We've got some stuff coming up pretty soon with some conferences and stuff like that. So we definitely need to get back on the air. Bradley.dean, how has North Carolina been treating you?
Oh, pretty good. Been on the road a little bit, been working some today, but the big thing is the conference coming up. This is the 50th conference, and that's why we're going to be covering it here in North Carolina.
Awesome. So you'll be seeing us back not only on our podcast platform with the Journal of Emergency Medical Services, but for those that haven't seen it, we also have our previous episodes coming online on the EMS Handoff by itself. So we're going to go ahead and jump in today, but before we get started, we'd like to thank our podcast partner, the Journal of Emergency Medical Services. While the EMS Handoff serves as your source for all things EMS, JEMS has been the source for the journal-based publication for many years. So make sure to go by and see them on their website. Give them a review as well. So, Bradley.dean, we're going to go ahead and just get right started like we always have. We've got a guest tonight that's got a very interesting topic. So, if you would briefly introduce it, and then we'll turn it over to our guest to finish that up.
All right. So, we're joined by I just lost service, but all right. So we're joined by Jonathon, who's been involved in EMS since 2009, has been a Pennsylvania and National Registered Paramedic since 2015. Jonathon earned a Bachelor of Science in Emergency Medicine from the University of Pittsburgh in 2016, and is currently enrolled in the Master's of Science in Emergency Services graduate program at Crichton University. He's a former paramedic rescue technician at Baldwin Paramedic Rescue, as well as EMS specialist with Excela Health, and a board-certified medical legal death investigator. And currently, he is serving as the program director of the Mutual Aid Excela Health Paramedic Training Program since 2021. Jonathon Jenkins, join us.
Thanks for having me. I very much appreciate it. I'm looking forward to it.
Now, really, with that introduction, Jonathon, I really just going to sit back now and just listen to your presentation and go at it. So,
yeah, no, I appreciate it. And I thank you guys. Thank you guys a ton for having me on. So my EMS journey is a little bit unique, and it took some turns that I didn't expect it to take throughout the course of my career. So if we rewind. Back to 2009, I went to EMT class, and I did like the summer fast track thing, where you go every day and instead of the 2 nights a week thing, because I was in high school. And so it's the summer between my freshman and sophomore year of high school. So I become an EMT. I'm 16. That's great. Problem, can't work anywhere until you're 18, right? So I'm from just outside of Pittsburgh, or the suburbs of Pittsburgh. So there really isn't a ton of volunteer opportunities around. So the town I lived in had an ambulance service, and I went down there and I knocked on the door, not knowing a soul. And I said, hey, I'm a 16-year-old kid. I'm an EMT. And I basically just want to work for you for free. And they looked at me like I was a crazy person. And they said, sure, sounds great. I basically spent my summer just hanging out at the ambulance station and riding, kind of doing I was like the ride along that never went. I'm like the ride along that never went away. I rode around and I went to calls, and it was great. And then I became a volunteer fireman with absolutely zero interest at all in fighting fire. I just wanted to go to ambulance calls because that was sort of my ticket in the door, right? Because I wasn't old enough to work anywhere. So I had like my normal high school kid summer jobs and became an EMT and became an EMT where I'm currently employed now and never left. If you would have told me that when I was in high school, I'd have never believed you. And here I am. I've always sort of been a science, math sort of driven person in high school and in college. So the medical field always really interested me. And I sort of I've always remained. Then I became a paramedic, and I remained in EMS. I dabbled into a couple things. I was affiliated with the coroner's office in the county where I live. Became a board certified medical legal death investigator. So I played around with that for a little bit, but never worked, never left EMS. Still like what I do. I've kicked around going to medical school and PA school, and just every time I try to do it, it's just like, I end up back on the ambulance, and I enjoy it. There's not a day of my life that I go to work and think to myself, wow, I wish I did something else. And then I got into teaching and became the program director of a paramedic program, and have a great team of people behind me that helped me with that. And it's been great. I love what I do. I love the journey. And I was fortunate enough to meet Bradley actually at a local EMS conference, which is how I got hooked up with you guys. He walked up to me right after my talk. I finished my talk, and the next talk started, there's like a 10-minute break. So I'm tearing my stuff down and trying to get out of the room and talking to Bradley at the same time. And he said, hey, I have this podcast that runs through GEMS, and it's the EMS Handoff. I said, oh, I know what that is. And that's sort of one thing led to another. And here we are. So I appreciate you having me. And the reason that we're here, or the reason that I think attracted, and Brad, please tell me if I'm wrong, was that my topic at the EMS conference where we met is really not sexy, right? That's how I introduced it. There's all these things going on around me at this conference that are all great, right? They're talking about blood, and they're talking about ECMO and RSI and all these cool things, and ultrasound. And then I go up into a room and I said, hey, let's talk about lift assists. And everybody just sort of looked at me like, really? Like, we're going to talk about lift assist? There's all these cool things. We're going to talk about lift assist. I'm like, yeah, we got to talk about lift assist, right? Because these people are really sick. And that's kind of how it started. So Bradley, from that talk I think I started back with a question to you. From that talk at the EMS conference that we were at, what about that lift assist topic do you think made it sort of most intriguing to you? And then I will sort of spin off of that and take this to where you need it to go, so I can take my 90-minute presentation and kind of condense it to what you guys think your listeners would like the most.
So one of the biggest things with that is, looking across all the calls that we run as, EMTs or advanced EMTs, paramedics, is, we run a lot of refusals, and we run a lot of falls, or, what some people just think as lift assist. And unfortunately, we go out and we pick up, Miss Jones in the middle of the night, put her back in bed, and the next morning the family can't wake her up because, maybe she bumped her head, she was on blood thinners, and people miss that on their assessment. Yeah.
And I think that is so important. So first of all, I have to tell you off the total topic, I have a 2-year-old that at this moment in life is very anti-bedtime. So if you hear some screaming going on in the background, that's what that is, because he just hates it. Anyway, but yes, I agree. So and I was talking to Dave before we started, if you think about like EMT class or paramedic class, right? We spend this much time talking about how we do CPR and stop bleeding and splinting and all these other things, which are really important, but we spend negligible time talking about how we mitigate these people that fall that are really sick. The person, just like in your example, what do we do for the person who, when we put them to bed and they were fine and they woke up and now they're not, right? Sample OPQRST, like that's all great. But at the end of the day, what do you do about it? Or the person who falls down 3 times in the same 12-hour shift and you go back and pick them up. Okay, well, yeah, it's really easy to fall into that trap of, they're a frequent flyer, they abuse the system, this, that, whatever your flavor is, however you want to call it, the people where we've decided before we even get there that they're not sick, or they're abusing the system, or they're a pain in the butt. And the reality is, if the system had met their needs, they wouldn't have called. right? Like if they could have gotten up, they would have gotten up, right? Like if you fell out of your chair right now while we're recording this, you would just get up. If you couldn't, that's weird, right? And I will be honest, what sparked my interest, I was never interested in this because I was that person. And I think just like we all were at some point, I think all of us, if you've done this for any length of time, has gone to a call and said, you know, or even, you know, out loud or in your head, this is annoying, right? That you're myself included, right? And I'm the one sitting here talking about this, right? I've been annoyed with that patient. And I never thought about it ever until last summer. I was cutting my grass one day and was listening. That's when I do like a lot of my podcast listening and stuff. I'm cutting my grass or in my car. And I was listening to Ginger Locke's Medic Mindset podcast. And she had Dr. Maya Dorset on talking about lift assists. And Dr. Dorset said, you know, that's not normal. Right. That was, I think that's actually what she said. Like, it's not normal. You're in your own house and now you have to call a stranger to come into your house to help you. That's not normal. That's weird. And she said about the system having not met their needs. And my wife, she will tell you to this day, I'm cutting my grass and I stopped in the middle of like my front yard and I came inside and I have a work laptop and I just started like looking at stuff. Like I pulled up all these stats. It's getting dark. My yard still isn't half cut. And I'm sitting at my kitchen table, you know, VPN'd into my office computer, looking at all these stats because everything she said in this podcast made sense, right? We have all these people who we think are abusing the system, but the system hasn't met their needs because we get there and we say, oh, okay, sure. We help you up. We put you in the chair and off we go. And the reality is these people have significant medical problems in a lot of situations. And when you look at the literature that's out there, yeah, it's few and far between, right? Like there's not a lot of awesome studies about lift assists, but there are several that have looked at it. And the ones that have looked at it have all basically said the same thing. These people are sicker than we think, and they're dying because we are not assessing them, right? Not taking them to the hospital, because not everybody that falls or calls an ambulance needs a hospital. Not everybody needs an emergency department. And it's perfectly okay to sign them off, right? Like if you want to refuse and it's okay for you to refuse, let them refuse. That's fine. Go ahead.
We had one of those specific examples, and I want to tie this where you are, because it was probably one that really opened my eyes. Like we had this 94, 93-year-old couple in our neighborhood, never contacted us before. All of a sudden, in one shift, we get them 3 times. Went and picked them up. They're like, hey, so thankful. I'm just not feeling well today. The next shift ended up picking them up twice. And the next shift picked them up twice. And so we come back after a 4-day break, and they had gone every day. And finally, when we go back over there, we ask the question, have you all just moved into the neighborhood? No, we've lived here for 70 years. Like, that's where they lived their whole life. It's like, why this week? Why? We are so sorry. We don't mean to disturb you. Well, come to find out, their son, who had been helping take care of them, had moved away. They didn't want to inhibit him, and they hadn't eaten in 4 days because they were too weak to get up and eat. They were at a point where if it had continued, we would have been going for something completely different. And sometimes it takes just slowing down and stopping.
Yeah. And I think, and like I said, if it's safe for you to refuse, right? Because some people do just fall, right? Like some people, like there is, Grandma Dolores is walking through her house and she trips over her cat and she's totally fine. And like, it was a freak thing that happened. Awesome. Like if it's safe, fantastic. But some people have this social determinants of health problem or even a medical etiology that we are sometimes, as paramedics and EMTs or first responders or firemen or police, you could lump it even to the police or whoever that interact with them, are the people that are sometimes the only people that have the opportunity to recognize that this is an issue. In your example, if they hadn't called an ambulance, nobody would have noticed that. Right? They've lived there for 70 years and nobody knew because they mind their own business and their son takes care of them and they do their thing and life is good. But one day when it isn't, they call somebody for help, and we have to approach it with that non-biased, open mind. Because when we walk in, because our shift is over at 6 o'clock and they call at 5:30, and we're already irritated because it's been a hard day, and 2 hours before that, we did CPR on a baby, like all that stuff is valid. But that doesn't mean that we should approach that with any less significance, right? So the whole gist of my talk at this conference was, let's, number one, recognize that this is a problem, and then revisit not just our, head to toe ABCs, OPQRST, AVPU, any acronym you want to throw in physical exam, but let's also ask the hard questions, right? When was the last time you ate? Are you able to walk? What if you don't want to go to the hospital, help me understand why that is so I can help you, right? And then being able to steward the resources that are available in whatever setting or whatever setting you work in. Like where I work, there's resources available through our ambulance service has an MIH program. We can sometimes refer people to that. The hospitals have in the area on aging and those sorts of things. Like there's different resources available that the lay public sometimes doesn't know about that we have access to. So are all the resources terrific? No, just like they aren't terrific anywhere, but they do exist, and helping steward those resources is really important. And my goal, as an EMS educator, I think, and talking to you guys and talking to my colleagues, every EMS educator has a goal, right? If there's something in your career that you want to do. And when I think about what that is, my goal, and everybody laughs at me when I say this, my goal is to just be the person that makes people understand that there doesn't have to be a difference between classroom and real life, right? Like, yes, there's always going to be a logistical difference, right? There's always going to be things that in the classroom I can't simulate no matter how hard I try, because the sky is the limit with creativity, with some of the people we take care of. I think we can all agree on that. But when it comes to assessments and lift assists and falls, you can simulate all of that. I can simulate a lift assist. I can simulate a challenging refusal. I can make students be cognizant of evidence-based practice and mobile integrated health and really bridge them together so that the way we teach this in a classroom and the way that we talk about it around the station or wherever, however your culture dictates it, doesn't make it so it has to be disjointed. When I go to a lift assist, I should go to that lift assist with as much enthusiasm and medical critical thinking, if not more, than when I go to a cardiac arrest, right? Because a cardiac arrest, yeah, that's important. And it's important that we're good at intubating. It's important that we can do CPR. But like ACLS is easy, right? If I see this, I do this. It can be hard, right? It has challenging moments. Undoubtedly, I've had cardiac arrest patients that I really had to think through. But if I see this, I do this, right? There's an algorithm for that. There's no algorithm for the lady in your neighborhood that's weak and hasn't eaten for 4 days and doesn't want to go to the hospital, right? That's not in a book. There's no chapter about that. So we have to, as EMS people and as EMS leaders and EMS educators, and if you're listening to this podcast, I would argue that you're an EMS leader, right? Because there are people that do EMS to make money and go home. And there are people that do EMS because they can't get away from it and they love it. And those are the people that lead, right? We're all here and we're all listening to this because in our free time, whether you're in your car, you're cutting your grass, whatever you're doing, you've chosen now to better yourself and listen to a podcast about your profession. So these are the people now that go back to their services and back to their agencies and talk about the not sexy topic, right? When we have our quarterly training or your monthly training or whatever you do, let's talk about lift assists, right? Yeah, we're going to do CPR updates and airway updates just like we always do, but let's talk about lift assists. Let's talk about refusals. Let's make sure we understand the rules, because that's where I think you can make a huge difference. So that's just me. That's just my opinion. And, there's a lot of, I'm pulling up just really quick on my other screen here, and to put it into perspective for you, like, so where I work, we have I have a large ambulance service, right? I have 265 clinical providers that work where I work. And in that service in 2022, we did, 16% of our call volume was, or I'm sorry, 16% of our refusals, I apologize, were ground level falls. And we have a huge elderly population, right? So our numbers are probably a little bit higher than the average, right? We have a lot of nursing homes, assisted living, and those kind of things. But that's huge, right? That's a huge, huge number. And I find it hard to believe that all those people just fell. And the worst phone call ever to get as a paramedic is, hey, remember that lady? Right? That's how it always starts. Hey, do you remember that lady? Right. And then there's like that long pause. And then it's like, well, like nothing good ever comes after, well, we took her because she had a stroke, or we took her because she was in a cardiac arrest, or we went back to her house because she died, and that's not a good phone call. And some of the literature that's out there, there was a study by Leggett et al. That came out in 2017 in the PEC journal that looked at this and increased morbidity and mortality in their lift assist and their ground level falls. And 1% of those patients in their study died within 14 days. 1% is not that much, but in their study, that's 420 people.
Well, if you take a look at that, though, that 1%, let's talk about what that 1% is. And you've already mentioned some of them. Less than 1% of the time we're doing intubations. Less than 1% of the time are we doing cardiac arrest management. Less than 1% of the time are we doing RSI management. And yet we focus so much time on that. Why are we not here? And I think that's important to say. You mentioned at the beginning, we spend this much time talking about this or this much time talking about that, but yet we're not really talking about this. And when you take a look at it, that number is actually rather substantial. That number is pretty staggering, because it could be that many more that we have an impact on even beforehand.
Yeah, absolutely. And like I said, I am by no means the lift assist refusal like content expert. However, and the people that I work with will tell you that my two favorite things to talk about are this and resuscitation. Like, that's what I like. Like the physiology of resuscitation. So it's like total polar opposites. Like if you're in the middle sick, I probably can't help you. But like if you're on one end of the spectrum or the other, I'm pretty good at it. And this is, this happens so much more, right? If you're a full-time paramedic, even a part-time paramedic, you can't work a shift and not encounter this, right? Like you can't. These people are in such a need. And I'll be honest, like up until probably, I don't know, 3, 4, 5 years ago, something like that, I had never heard of community paramedicine or mobile integrated health, right? I took a class on it in my undergraduate year in college, in my senior year, in Pitt's emergency medicine program. And I took that class because I had to fill a hole in my schedule. And I thought to myself, I like taking care of sick people. I will hate this. And it was my favorite class that I took that year. And a really good teacher. It opened my eyes to all these things, because really, like if you think about the people that that you hold in your mind as the best providers that they are the people that have effectively bridged their clinical practice to reflect not only acute care medicine, but mobile integrated health and social work and all of those subtopics. And they've merged them together to encompass what EMS is, right? The future of EMS, I think that we can all agree, isn't going to be lights and sirens 90 miles an hour down the road, right? The future of EMS is, we do that a little, and most of what we do is help these people that aren't actively dying, but still have a huge need.
Well, I'm going to take this into a completely different realm. And you saying you jumped on the fire truck not wanting to be a firefighter, there's some fault in your logic there. You always want to be a firefighter. Sorry, that's my background there. But you take a look at this. What you're talking about now is getting into what the fire department has done basically to try to put itself out of business. In the past, they fought fires. I talked to people in the past 30, 40 years ago. They're like, yeah, we were passing fires to go to fires, all these fires that were occurring. And through codes development and through codes enforcement and new building materials and education, and all of this different stuff, they don't put out fires anymore. That's almost a secondary job. They're doing hazmat response, rescue calls, EMS calls, because they worked on this different area. Now, what you're talking about, getting into MIH and community paramedicine, or even some of this, knowing the social side of things as far as getting resources to people, that is basically trying to say, hey, we're trying to get you to a point where you're not calling 911 anymore and freeing us up for those more freak incidents that do occur. Would that be an analogy that you would agree with?
Yeah, I think that 100%, 100% makes sense. And, and I'll jab right back at you. I can't be a fireman. I wouldn't look good in the outfit. That's just what I tell. That's what I tell everybody. I literally, in my time as a volunteer fireman, went to one fire, and it was by accident. There was an ambulance call, and we were on the way back from the ambulance call, and there was a fire. And I was like, what do I do at a fire? Like, I don't know. But I was, I had a great experience as a fireman, and I learned a lot. And I worked in an ambulance service. It was called Baldwin Paramedic Rescue in the South Hills of Pittsburgh, in the suburbs of Pittsburgh. And what we did was basically, we were an ambulance service, but we had rescue capability, and we did a lot of medically directed rescue. And I learned more about rescue in my time there than I ever thought I wanted to. And it was fantastic. I'm not very good at it, right? I always joked with the guys on my shift, if you bring me the patient, I will help you fix them. But like, getting them is probably not going to be my forte. But I learned more than I thought. And you're correct, because the fire service said, we fight fire and we can do that really well. And then they started doing all these other things. And as things became safer on the fire side, right, with codes and everything that you said, they went to less fires, but they did this other stuff more. And now they focus a lot of their efforts onto this other stuff, but we're still really good at fighting fire, right? And as paramedics, I think that we have to switch our gears a little bit to, we are really good at resuscitation and all these things when we need to be, but we spend most of our time doing this other stuff. And I think, and this is just my opinion totally, and it just doesn't reflect, any of my my employers or anything like that. I think we market EMS incorrectly. It's just my opinion. As an industry, I think we market it incorrectly. We market EMS by jump in the ambulance. We're going to go 90 miles an hour down the road. We're going to pull 16 babies out of a car. And when we're done with that, we're going to go deliver 10 more. It'll be fantastic. The reality is, I've been in EMS for 14 years. I've delivered two babies, and I have done a lot more old people that fell down and needed help up than anything that we just mentioned. I've been to bad crashes. I've done CPR, but we don't do it. And there's places they post pictures of all this stuff on their Facebook page, because the picture of grandma that fell doesn't market well.
And that's one of the reasons when you get into talking to people in the retention side of EMS, they get in expecting, lights and sirens going 90 miles an hour 12 times a day. And really it may be 12 times a month or less, and 40 times to something else. And just to toss that up there, I put it up there. I was supposed to deliver my first of two children. We said don't worry about it in the second one, but I've actually delivered a sum total of 0 children in my greater than 20-year career. So
right, but how many falls have you been to?
Ton.
Right.
I couldn't tell you. And just like I said, just that one couple, we went to that couple 7 times before we got all of their issues resolved. So that's just on that one couple.
Well, and even even in our heads, right? You can tell me immediately, I've had a greater than 20-year career. I've delivered 0 babies. How many falls have you been to? I don't know. Right. Because it's not something memorable. When you go to that career call, you remember that. but, the bad crash, the MCI, the whatever, whatever your flavor is. But there's a lot of times where the falls and the lift assist, and it doesn't even have to be falls and lift assist, right? It could be chest pain, it could be belly pain, whatever it is. That's a career call. And I took a class, I took a rescue task force instructor class one time. And the instructor was a guy who I'm not even exactly sure what his exact title is, but he was affiliated with Seattle SWAT. Seattle SWAT, the National Tactical Operators or Officers Association. And he said in this class, nobody ever calls 911 for the B team. And I thought about that. It was one of those things that somebody says and you park it in the back of your head and in the quiet of your drive home, you're thinking about it. And I thought about that. Nobody is having a terrible day and says, I hope the mediocrest paramedic ever comes when I need help. Right. They want the people that are astute clinicians. If you needed a heart transplant, you wouldn't go say, give me the great value brand, heart transplant surgeon. You want the best one that there is. And people fly all over the world for that. When people call 911 because they fell or they have chest pain or belly pain or whatever, we should give them that experience. Right? We're healthcare professionals. We are professional clinicians, and they deserve a head-to-toe clinical exam. And one of my last slides in this, and I'll just read it to you. It's time that we move the stigma from you call, we haul to if you call, you will receive a sophisticated clinical evaluation and high-level care based upon evidence-based practice by 100% of the practitioners 100% of the time. And
I love that. There is so much to unpack with just that one comment right there, because let me ask you this. You say you call and you want the A team, or you don't call for the B team. So when you call for fire department, what are you expecting to get? And they've done a good job of saying, okay, we're here if it's on fire, we're here if it's medical, we're here if it's car wreck, we're here if it's this. What do they do when they call for an ambulance? They expect to be taken to the people that are going to care for them. So that, I think, may be, a place that we can educate the community to say that last slide right there. It's not, we're going to pick you up and take you to the hospital. We're going to pick you up and take care of your needs, whatever that is. It's either going to be us, and we're going to get you back to doing what you're doing. We're going to get you there to your physician or the doctor with some of these new, like ET3 and some of the different things that have come out through COVID. And it may not be going to the hospital. That may not be what it is. But people think of, I call an ambulance and they take me to the hospital, not I call and they get that excellent care.
Yeah. And I think, the other side of that is we have to address the elephant in the room. The EMS system was set up, from a reimbursement perspective. We take you to the hospital, we bill your insurance, Medicaid, Medicare, whatever it is. We get something back from that. Usually it's not what we bill. And what you get is what you get, because a lot of times it costs you more money to track down the difference than it would to just eat it, right? So the other side of this is the CMS and all of the insurance companies and the players, they have to recognize too that there's been this evolvement of EMS, right? EMS is not just we come to your house, we take you to the hospital, we drop you in the emergency department, repeat. Because I don't know what the exact numbers are, but I would argue that probably 80% of the patients that I take care of don't need an emergency department, right? They need a PCP. They need inpatient or outpatient rehab of some kind, right? Whether that be drug rehab, physical therapy, occupational therapy, whatever. They need an urgent care. They need whatever, I don't know what that is, social work. But most of them don't need the emergency department. And unfortunately, the default answer is, as EMS people, when somebody calls 911 and we don't know what to do, we take them to the emergency department, right? When other healthcare people don't know what to do, they say, go to the emergency department. And then the emergency departments are overcrowded because they then don't have anywhere to put these people. Like the whole system the whole system is flawed, but it's flawed from the inside, right? And I think that sometimes we have to be the people that recognize, hey, this isn't working. So we have to figure out a way to then facilitate and lobby on many different levels, from a community level the whole way up, to say, hey, this is what EMS has evolved to. How can you help us afford to do it?
And this is, so we're still in the model of the accidental death and disability white paper. The morbidity and mortality associated with interstate wrecks as the interstate was being built up was substantially high, and the only people to fix that was the hospital. So we sent out, at that point in time, funeral homes, which kind of ties into your medical legal investigation. But the funeral homes would come pick them up, take them to the hospital, or take them to the funeral home one way or another. And then we've adapted, we've adjusted, increased our capabilities, but the system has remained pretty much the same. The only goal is to get them there. When we have some very highly, and I love the terms that you utilize, you can definitely tell that you've talked to my Dorset a couple of times, and the terminology of clinicians and practitioners and such, that we've had that shift. And if you haven't yet, I recommend reading a paper out of New York here recently, the 2023 evidence-based agenda for the future for New York. And a lot of that stuff is there. And one of the key terms that they mentioned there is the cost of readiness, which would adjust how EMS is done. But that would allow us to say, hey, look, I've got Paramedic Jenkins out there, and he is the cream of the crop, but he's taking care of you. All you need to do is do this, follow up with your primary care physician tomorrow. If you have these specific things, call me back. But right now, you're good.
Yeah, and I think, so it's actually funny. I've never met or talked to Dr. Dorset ever in my whole life. I'm a fanboy, right? Like I like what she does. Like I like her research. I like what her stuff through the NAMSP education committee. Like, I think it's great. If you hear this, like, I'm a big fan. I would love to work with you, but never actually met her. And it's hilarious because Ginger Locke and Dr. Dorset did that podcast and totally altered the way that my ambulance service where I work did this. And they have no idea. Like, this just became like Jonathon went out on a limb, like on a crazy idea. And like, we altered the way that we approach these calls from a podcast that I listened to while I was cutting my grass. So like, it's cool how the EMS community is interconnected like that. But if you read the New York agenda for the future, it talks about a lot of things. And one of the things that it talks about in that cost of readiness is a career ladder, right? So Bradley.dean enters the EMS service as an EMT, and he's a really good EMT. And he does that for a couple of years. So he wants to go be a paramedic. So he becomes a paramedic. And then he does that for a couple of years, but he's like Jonathon and he gets bored. So then what does he do? He becomes a critical care paramedic. So then he does that for a while, and then he teaches, and he does that for a while. But like, so then you get to that point, you're like, okay, well, what do? I become a supervisor of some kind, or I go fly, right? And like, that's sort of it. And then you get into this whole topic of, do paramedics need degrees? And I will tell you that I used to be the drum major of that band. Like, if you're a degree, you need if you're a degree, that makes sense. If you're a paramedic,
if you're a degree, you need a paramedic.
If you're a degree, you need a paramedic. If you're a paramedic, you need a degree, and that's it. I used to be like that person waving that flag. And when I got into grad school, so I'm almost done, and that's when I changed my tune, because I'm a paramedic. I'd like to think I'm a good one. I have a bachelor's degree. I'm a program director. I'm almost done with a master's degree, and it's awarded me opportunity, right? I'm sitting here talking to you guys. I've written some things. I have a podcast. Like, it's afforded me a lot of great opportunity. But if you have chest pain, it doesn't matter. And because I don't have an advanced scope, I don't have any of that stuff. And I think that we have to figure out how to make EMS, what's the reward, right? I got a master's degree because I didn't want to ever be in a position where I couldn't do something that I wanted to do because I couldn't. And I have a 2-year-old, so I did it when I did it because I knew that as he got older, life wasn't going to get less busy. So that's why I did it. And I was fortunate enough to be able to do it. But what's the ROI on that for somebody who just says, I want to be a paramedic? I think that we can cherish those people and somehow figure out a way to make it work. That's just my opinion.
Well, first off, I'll send a message to Dr. Dorsett and let her know that you're fanboying on her.
Oh, great!
And we'll get that. But she actually was my second site visit. We were talking about this before we got started, but she was one of the site visitors for my second site visits, and learned a tremendous amount from her. There's a question she loves to ask clinician versus technician. And, I think what you're saying, even with that, goes back to the topic that we've been talking about, is like the advancement of this profession and getting deeper into each of those patients. And by doing all of this stuff, we shift and adjust what we are doing. So I am one. I still beat the drum of the education, and even if it's not a paramedic degree, I do always seek as an individual. I'm actually working on my second master's now in public health because it's fun and I learn a lot. I'm in biostatistics right now, and if you're not, I have a great professor, which makes it even better. But if you've never taken biostatistics, it's fun. But
it's something.
It is something. But it's one of those things. Tying back to what we're doing and what we're talking about, what we've gotten talking about now is that's kind of how we advance our future in the care of the patients and open up these